morning, colleagues. I hope you're all well. On behalf of the Allergy Society of Kenya, we welcome you to this Allergy Society workshop that we're having in conjunction with the Kenya Pediatric Association as part of our annual meeting. And I'm here today to talk about, is asthma a preventable condition? Before I go ahead and proceed, I'd just like you to know that the Allergy Society of Kenya is going to be having its AGM and its elections in the next 1 month. And we'd like to encourage all of you to participate, join hands with us as we are all one in managing asthma and allergic diseases in Kenya as a whole. I'll come back to my topic now, is asthma a preventable condition? And my first slide is to prevent asthma, what we need to do is look for the conditions that cause children to have worsening cases of respiratory disease. And probably one of the most important pertinent things that one needs to consider is preterm births. Preterm births are not only just a condition that's going to give you associations with the significant asthma and asthma-like phenotypic presentations, but it's also going to give you poorer lung disease overall. So this is something that we need to try and avoid as a country in order to rid or at least alleviate the morbidity associated with asthma and prem births. So the whole idea is to have good antenatal care, to make sure that pregnant women are going up for their checkups and that they're in good nutrition and they're in otherwise good overall health. The health of our mothers and the health of women who are within childbearing age is directly proportional to them having healthy children who are not prem. And if you have a child who is not prem, then you're going to have a child who has airways that are not vulnerable to the scourge of asthma. So improving maternal knowledge and health-seeking behavior is also very important in this regard. Just so that we are all clear and that we're always on the same page, one of the definitions and types and phenotypic types of asthma is transient wheezers. And in the transient wheezers, these are children who are born with smaller airways. And because they are born with smaller airways, when they get viral and respiratory insults, they are more likely to present with polyphonic wheezing disorders between the age of 1 and 5 years of age, at which point in time they then outgrow their asthma. So hence the reason to ensure that that baby who is going to be born 1.3 kilos, if we can get that child born 2.3 kilos, for example, then we will be able to prevent that child from having a transient wheezing asthma phenotype, which is what today's discussion with you, dear colleagues, is all about. So to take you then to my next point is the prevention of biomass fuels. Studies have shown, and I'm sure many of us are aware, that if the mother or if a pregnant lady is smoking in pregnancy, then there's a very high chance that she's going to now also give birth to a child who's going to have asthma within the first 3 to 5 years. Studies aren't absolutely sure as to what and how this happens, but there's a lot of thought flow processes on what the nicotine levels do to the developing lung and airway formation of the fetus in utero, and that this then leads you to having an asthma phenotype later on in life. Now, this was now a surprising study that came out recently that showed that even if the grandmother had a history of smoking in pregnancy, her second generation offspring could also have an increased risk of asthma. So what we're trying to say is, we're not saying that the men can smoke, but what we're saying is that if a pregnant mom, a pregnant lady is smoking, the chances of her having a child with asthma is significantly increased. And so we need to focus on people stopping from smoking, but especially the female childbearing population. That does not give license to the men who are listening to me to smoke. So we strongly encourage all populations not to. Now, Kenya is now moving from a situation where many of us were in townhouses, and now in most bigger cities, we are having urbanization, and accommodation now is happening in a third-story building and a fifth-story apartment. And of course, these buildings are getting smaller and the apartments are getting smaller. So if you're going to burn kerosene, firewood, charcoal, scented candles, incense, all these things, mosquito coils that you can see, and these bullets highlighted below, you will, it's at the end of the day, it's like a mother smoking, for example, that we are increasing the amount of biomass fuels, and we need to try and reduce these, because not only will this affect the unborn fetus, but it will also worsen asthma in children who already have it. So a lot of these can cause irritant bronchitis and will increase the amount of airway inflammation. And as all of us are aware, if you have more airway inflammation, you're going to have the need for more anti-inflammatories and steroid medications for your child's asthma. So removing a lot of these biomass fuels from an environment can prevent not only the development of asthma in the unborn child, but also worsening of the asthma in the child who is born between the age of 0 to 5 years and thereafter as well. The last bullet mentions oud, and I think in the land of medicine, we also need to know our customer, i.e., a lot of people of Somali descent, in particular, burn something called oud or luban, which is a sweet-smelling wood that they light on fire, and then they take the smoke throughout the house, and it leaves huge clouds and plumes of smoke and smoke debris within the environment, and this can worsen asthma and its manifestations. So this is something that is important for one to remember. There are a lot of studies as to whether ozone can and cannot cause the development of asthma, whether it can lead fetuses to have immune dysregulation and poor airway development. And studies have shown that when ozone levels are particularly high in some areas, that the children tend to experience a greater tendencies to developing asthma. But please remember that these are not consistent studies. Worldwide, there are some pockets that have shown that this is the case, and there are other pockets that have been largely unclear. So we probably need to do more epidemiological studies to see if there is a long-term consequence of ozone playing a role in the development of airway disorders in children. I know that today I've been given the talk of preventing asthma, but as I go through these presentations, you will realize that not only is it a question of preventing asthma, it's actually good lung health that we're going to eventually be discussing. So whether these things will prevent asthma or prevent chronic obstructive airways disease or persistent bacterial bronchitis in children or later on COPD, I think the point is met that in order to develop and have good lung health in our children, a lot of these things will have to be addressed at the national level, governmental levels, and at the world stage as well. The role of RSV vaccination is now something that I think is very important. I know all of us have waited for this COVID vaccine to come through, and hopefully we have something now that is showing. But the RSV vaccine has also been in development over the past 10 to 15 years, and a lot of phase 3 trials have already taken place across the world in pregnant women who are offered the RSV vaccination in the 3rd trimester. So as pediatricians, we're always interested in the health of the fetus. So a lot of these vaccine trials have shown that they are safe and that there is no consequence to the unborn child. So we know that the RSV vaccine in pregnant women is safe. But also, secondly, that this vaccine does give formation that then goes transplacentally into the child and protects the child up to the 1st year of life and even slightly thereafter from developing RSV bronchiolitis in the 1st year of life. So to have an RSV vaccine in a pregnant mother, well, if we can protect the mother, we can then protect the child with the antibodies. And if we can protect the child with the antibodies, studies have shown that RSV bronchiolitis may predispose you to future asthma development. So if I can prevent RSV in the infant, it is then theorized that I can then prevent asthma development in that same patient. This will always be something controversial. We will never know the truth of this statement until after rolling out the RSV vaccine for pregnant women throughout the world, and we will then have to take it at that point in time. But at the end of the day, this is now, we're trying to look for any hope that we can have to prevent the rise of this non-communicable disease in the world. And this is one of the avenues that researchers are looking at to see if we can make a difference. When it comes to the hygiene hypothesis, the whole idea was that if we live in a slightly dirtier environment with more microbiomes, then maybe we will have our bodies and our body immunity and our T helper cells start shifting towards more of a Th1 response rather than the Th2 response, as is what is postulated with the hygiene hypothesis. So I know my first slide and my first bullet of should we eat dirt is a terrible one to start with. But sometimes when you're thinking about the role of the hygiene hypothesis, you wonder if that's where we might actually have to go, or to go back to the farms and have our younger people, grow up on farms. But how many of us can sincerely do that? Can the farm come to the house? Can we just have a pet and a pile of dirt in the house and think that that will make asthma a little bit better? Or should we take our children very early to school so that we help them develop more of a Th1 type of phenotype? Or take them too late to school because that might help balance their Th1, Th2 phenotypic profiles and hopefully not have them present with asthma later on. Lastly, when it comes to the hygiene hypothesis, is it useful to have probiotics alter your gut microbiome with the hope that it will give you more of a Th1 type of response, so that later on, when you're having an allergen exposure, maybe we'll have more of a Th1 response and help not, and thus not have a patient present with wheezing later on in life. And all these bullets that I've put up have had multiple studies done in multiple countries. And for every one that you have a slight positive, i.e., it was a good idea, there are 2 or 3 studies that have shown that it does not work in trying to reduce asthma. So after all these several bullets and thought flow processes, we're still unclear as to whether any of this will help alleviate asthma and asthma presentations later on in life. So sorry to give you such a long, drawn-out negative response, but it's important that we're also all on the same page. Now, there's several studies that have been taking place, especially in New Zealand and in Australia, where it's even moved to phase 3 trials, and that's the role of an oral bacterial lysate. The common one that's being used right now is the OM85. The whole idea about this is to orally provide OM85 in drops into children's mouths, almost like a probiotic-like. And this OM85 is supposed to work like an immune training agent. Remember when in the previous slide I talked about should we eat dirt? Well, this is a conversation because many of the listeners today are of various cadres in the medical front, and we must always work and move together. So this oral bacterial lysate, which will not give you septicemia, it's just a particle of a bacteria, is like an immune training agent so that your body is bombarded with micro dirt particles that give you more of a Th1 response, as you can see from bullet number 2. And it's hoping that it will also attenuate the exaggerated Th2 response that you see in children who have asthma. And a lot of these early studies in New Zealand, they worked with up to 3,000 to 5,000 children, showed that there was an association with the reduction of severe lower respiratory tract infections and their consequences. So not only did this help reduce the amount of pneumonia and viral bronchiolitis, but the incidence of asthma and asthma exacerbations was also reduced when we were in children who were receiving the oral bacterial lysates. Of course, this study now needs to be replicated in other parts of the world so that we can then see if this is actually going to be meted out. But what was useful was that lower respiratory tract infections, i.e. pneumonia, was also attenuated. And that's useful. So as allergologists, as pulmonologists, as pediatricians, nurses and clinical officers, we also not only want asthma exacerbations to go down, but we are also interested in pneumonias to also go down simultaneously at the same time. This is going to be one of my most important slides. We mentioned that a lot of Kenyans are now staying in one-roomed apartments on the fifth floor of a building, etc. And you know, if you don't have a playground, if there's no tree to climb, if there's no way to run and play and have fun, and you're with your iPad and your iPhone and your PlayStation, and the kitchen is just 3 steps away, then of course obesity is going to increase with these apartments and electronic devices. Now, your Uber Eats and your Glovo makes every food that you would want to eat 20 minutes away. And so this culture of having food coming to home, not having play areas, will obviously increase the scourge of obesity. Children who are obese have pressure effects causing airflow obstruction. They have increased leptin levels, which are making it a more pro-inflammatory milieu within the body, which makes you also respond very poorly to inhaled corticosteroids. Should you have frank asthma? Patients who have obesity also have a lot of pressure effects of the weight of the fat around the thorax compressing the airways. They have a higher incidence of GERD because their intra-abdominal pressures are extremely high. And all this will worsen because you will increase vagal responses and cause basal bronchoconstriction within the airways. And when you give steroids, they will not work that well. Children who are obese, the steroids given to them work far less better than their thinner counterparts. And so this will also worsen asthma exacerbations and asthma outcomes. And so we need to also address obesity if we want to address the increase in asthma that we are seeing within our country and in the rest of the world. I don't mean to be controversial with this particular slide, but you know, sometimes I think I always tell people just because a vaccine exists doesn't mean that you need to use it. There are a lot of strange vaccines out there in the world that don't actually meet the standards of what we are expecting of them. So in the past, the influenza vaccine would even have efficacy levels of up to 20 to 30% as near back rather as 3 to 5 years. So its efficacy is actually quite low when you look at it over the past decade. However, there's been a new tetravalent strain that has been put out, which hopefully will increase its efficacy. So until that point in time, yes, giving any anti-flu vaccine will make a difference in the exacerbations that children are going to go through. But it's also important to understand how much of a reduction this is going to be. And we need to also be clear about that as pediatricians and as people who work and look after children. Now, what about allergy testing? Will allergy testing a child who is born to a highly atopic family prevent that child from getting future asthma? So let me repeat that again so that we are all together on the same page. Say you have the father and the mother who are very, very atopic and allergic, and they got 2, 3 children who are very allergic and asthmatic, etc. And they have other relatives. So you're entering an atopic family, and this child is born, and you do RAST tests on the blood of the child, and you find that house dust mite, there is an IgE to house dust mite that is quite high. Will house dust mite avoidance really help prevent that child from getting asthma later on in life? The answer is no. The same for roach and mold and rat and cockroach and horse and most other conditions. That allergen avoidance before the presentation of asthma will not prevent asthma. I hope that statement is clear. But there is mixed Cochrane reviews and mixed systemic meta-analysis that suggest that there may be a role in reducing exacerbations. So this is a child who already has asthma, but then the exacerbations are reduced thereafter by house dust mite avoidance, cockroach avoidance, mold avoidance, cow milk avoidance if the child is sensitive to those particular ones. So this bullet is slightly controversial. So in summary, I hope I've not lost you. You cannot prevent asthma by avoiding these allergens, but you may possibly reduce asthmatic only if you are sensitive to, sensitized rather, to these particular conditions. So, what about the role of micronutrients and vitamins? Because we remember that Shosho told us that, oh, if you have cod liver oil and Scott's emulsion, all will be well and you will never get a cough and a cold. What about hypovitaminosis D and A? The take-home message for this entire slide, and there's some references there for you as well, is that uh, giving administration of these vitamins and emulsions to children will not prevent that child from getting asthma, and also will not prevent you from getting asthma exacerbations if you were an asthmatic. So the take-home message is that none of these vitamins will make a difference in your child getting asthma or having worsening asthma. So we strongly encourage you not to give these medications to your asthmatic child. You'll be wasting a lot of money. Please remember, I was horrified the other day when I went to the pharmacy and I saw somebody buying Scott's emulsion for 1,300 shillings. I thought it was a 200 shilling medication, and it was, I was surprised to see the cost of what we are wasting our resources on. Please remember that even some of these medications have flavorants, fortifiers, sulfites, E numbers. So a lot of these syrups that you're giving our children have to be fortified and kept as such. So you have to be very careful, because a lot of these can also increase the amount of inflammation you're having within your body. And remember that when I wanted to say when I was growing up, but about 10 years ago, there was a study that came out that said that if you used cetirizine in children who are 6 months of age, you would who were born to an atopic family, that you would prevent them from having the allergic march if you gave cetirizine every day to a 6-month-old baby for the next 6 months to 1 to 2 years. And even when I heard of the study, I was horrified with the thought of how would cetirizine prevent the atopic march. This study was published in a peer-reviewed journal, and it was sponsored by the major manufacturer of cetirizine. So you can just imagine, you can fill in the dots with that statement. Several studies in several countries thereafter proved that cetirizine for 6 to 9 months does not prevent the atopic march. You can just imagine the amount of children who had to consume huge amounts of cetirizine in order to avoid something that eventually caught up with them. So we are strongly suggesting that cetirizine is not used to try and prevent asthma in children who come from an atopic background. So as you can see, I haven't really given you much hope as to whether asthma can be prevented, but I thought I'd put in a slide of hope, and that is that can asthma exacerbations be prevented? And I think that's, I'm smiling now because that's a little bit easier for me to handle, and I'm sure a little bit easier for you to listen to. And that is that regular use of inhaled corticosteroids will definitely reduce asthma exacerbations. There's a new mindset that has come out, which I firmly adhere to in my practice as well. And I strongly recommend it as well, which is increasing the dose of inhaled corticosteroids in an early exacerbation will reduce the amount of oral prednisolone and the amount of extra medications that a patient might require. Just so that we're all on the same page. Say, for example, a patient is taking budesonide, 100 micrograms OD, as a regular therapy for their asthma. What is being suggested, and a lot of work has come out positively in this regard, is that you can ask the patient to pentuple, if not even more, the amount of ICS. So they take the same budesonide, but now 3 puffs BD. So like 300 micrograms in the morning and 300 micrograms at night for a couple of days with salbutamol rescue. And that can reduce the need for oral corticosteroids. And I urge you to watch this space, because I have a feeling that that's where we're going to be taking pediatric asthma care into the future. This is my last slide, and I hope I have kept time. In summary, I haven't given you too much hope in the near future, but studies are showing that early life exposure to these allergens that we've discussed today, the house dust mite and the pets and the roaches and the rodents, etc., combined with the air pollution, nitric dioxide, which we didn't talk too much about today, but we did talk about ozone and these VOCs and particulate matters and viral respiratory tract infections that we have discussed today, have been implicated in the development of asthma in high-risk children. And it is hoped that if you try and avoid these in sensitized children, you may reduce the development of asthma in these high-risk children. So I think what we need to do is identify families who are at high risk of developing asthma and ensure that at least we are not burning wood in the house and that we're not burning incense in the house, etc., and trying to delay the onset of viral respiratory tract infections, like providing RSV vaccinations to pregnant women when it does come. Biodiversity in the perinatal period may actually develop the development of atopy and asthma symptoms later on. I remember that bit that I talked about eating dirt and staying in a slightly more dirtier environment. I don't know how that will go down with us not cleaning our houses and our homes in Kenya, because that will also encourage the development of mold and cockroach infestations within our home. And so it might be counterproductive to actually have a dirty indoor environment. I hope I have succeeded in completely confusing all of you. As you can see, there is still a lot of work to do in asthma prevention, but I hope that we've at least shed some light on the complexities of this condition. And I welcome your questions. Thank you for listening to me today.